Imagine an organ inside your body that is designed to digest food but suddenly starts digesting itself. That is exactly what happens in pancreatitis. And within hours, this condition can progress from severe abdominal pain to shock, respiratory failure, kidney failure, and even multi organ dysfunction. In today's video, we'll understand pancreatitis in a simpler way so that it helps you in your exams as well as clinical practice. Pancreatitis is inflammation of pancreas caused by premature activation of pancreatic digestive enzymes leading to autodigestion of pancreatic tissue. Now let's understand the key concept flow. First is the premature enzyme activation. Second, it leads to autodigestion of pancreatic tissue. And third, it leads to inflammation and tissue damage. Key point is the pancreas begins digesting itself. Now, pancreatitis is of three types. Acute pancreatitis, which is a sudden inflammatory process that may be reversible. Second, chronic pancreatitis, it's a progressive inflammatory disorder causing irreversible fibrosis and loss of pancreatic function. And third is recurrent acute pancreatitis, repeated attacks of acute pancreatitis without permanent or structural damage. Now let's discuss the etiology and the risk factors of pancreatitis. First, gallstones. It accounts for almost 40 to 50% cases. This is the most common cause because the gallstones may lead to obstruction of ampulla of Vater, which leads to reflux of bile and enzyme activation. Second, alcohol. Around 25 to 35% of the cases are because of excessive alcohol. Chronic heavy use causes a direct injury and protein plug formation in the pancreatic ducts. Third, metabolic causes. Hypertriglyceridemia above 1000 mg per dl and hypercalcemia also lead to pancreatitis. Metabolic derangements trigger enzyme activation and cellular injury. Fourth, drugs like azathioprine, valproate, thiazides, steroids, estrogens, etc. And cause number 5, other factors like trauma, infection like mumps, cytomegalovirus, autoimmune disease, ERCP, anatomical abnormalities, idiopathic causes accounting for 10 to 20% of the cases. Important point is identification of the cause is crucial to prevent recurrence. Now let's revise this in the short mnemonic. The mnemonic is get smashed. G for gallstones, E for ethanol or alcohol, T for triglycerides, S for steroids, M for mumps, A for autoimmune disease, S for structural abnormalities, H for hypertriglyceridemia, E for ERCP, and D for drugs. Now let's understand the pathophysiology, how exactly pancreatitis happens. First is the premature enzyme activation. So premature conversion of trypsinogen to trypsin within the pancreatic SNR cells instead of in the duodenum. Second, autodigestion. Activated enzymes include trypsin, lipase, elastase, and phospholipase A2 digest the pancreatic tissue, causing cellular injury and necrosis. Third, inflammatory response. Release of inflammatory mediators leads to local inflammation and recruitment of immune cells. Inflammatory mediators like IL-1, IL-6, TN-alpha, PAF, and bradykinin. And then local and systemic complications. Local tissue damage, cytokine release lead to systemic inflammatory response syndrome called as SIRS and multiple organ dysfunction. Complications include ARDS, AKI, and shock. Clinical features. Now let's discuss the clinical features, signs, and symptoms. Primary symptom, severe epigastric pain radiating to the back. Pain is boring or penetrating in nature, usually sudden in onset, worse after eating or lying supine. Pain may be relieved by leaning forward. GIT features like nausea, vomiting, abdominal pain, absent bowel sounds in severe cases. Systemic signs like fever, tachycardia, hypotension, indicating hypovolemia or shock. Now the hemorrhagic signs, which is the most important part, Curran sign and Gray Turner sign. It suggests retroperitoneal hemorrhage and severe necrotizing pancreatitis. Respiratory features like tachypnea, hypoxemia, pleural effusion, which is usually left-sided, may progress to ARDS. Now diagnosis and severity assessment. Diagnosis requires any two of the three criteria. First is the characteristic abdominal pain, epigastric, often radiating to the back. Second, Amylase lipase elevated more than 3 times the upper limit of the normal. Lipase is more specific and remains elevated for a longer time. And a third criteria, characteristic imaging findings of acute pancreatitis on ultrasound, CT or MRI. Now let's discuss the severity assessment. First scoring system is BISAP. B is blood urine nitrogen about 25 mg per dl. I for impaired mental status. S for SIRS 2 or more criteria. A age above 60 years. P for pleural effusion. Score greater than or equal to 3 means severe pancreatitis. Second scoring system is the Ranson's criteria, which usually determines the severity within 24 to 48 hours of the presentation while admission. Age above 55 years, WBC above 16,000, blood glucose about 200 mg per dl, LDH about 350, AST about 250, and after 48 hours, hematocrit falls above 10%, BUN increases above 5 mg per dl, calcium below 8 mg per dl, oxygen saturation below 60 mm of mercury, base deficit above 4 milliequivalents per liter, fluid sequestration above 6 liters, score greater than or equal to 3 again means severe pancreatitis. Now let's understand severity correlation and mortality risk. 0 to 2 less than 1% mortality, 3 to 4 around 15% mortality, 5 to 6 around 40% mortality, 7 or more means very high mortality. More criteria means more severe pancreatitis. Complications include SIRS, respiratory failure, renal failure, shock, organ dysfunction. Now, what are the investigations which you will advise? First, coming to the lab test, amylase lipase being more specific because it remains elevated for a longer time. CBC may show leukocytosis and increase in the hematocrit. CRP elevated because of inflammation. RBS will be elevated. Urea, creatinine, electrolytes, LFT, calcium may be low, and ABG in severe cases. Now coming to the ultrasound. First line imaging modality detects gallstones and biliary dilatation, may show pancreatic enlargement, edema or peripancreatic fluid, best for identifying biliary cause for pancreatitis. Now coming to the contrast CT scan, usually done after 72 hours, 296 hours unless patient is deteriorating, best for assessing the severity, necrosis and complications, helps in calculating CT severity index, gold standard for severity assessment and detecting complications. Now coming to the MRI or MRCP, excellent for evaluating biliary and pancreatic ductal system, best for unclear etiology or choledochocolelithiasis and anatomical abnormalities. It is used when ultrasound is inconclusive or ERCP cannot be done immediately. Other investigations like serum lactate, where high levels indicate severe disease and poor prognosis, ECG to rule out cardiac risk or severe illness, chest X-ray to detect pleural effusion or ARDS, urine analysis may show increased amylase, blood culture if infection or sepsis is suspected. So early and appropriate investigations lead to accurate diagnosis, severity assessment and better outcomes. Now let's revise the high-yield clinical pearls in acute pancreatitis. First, the classic presentation, severe epigastric pain radiating to the back plus vomiting is always acute pancreatitis unless proven otherwise. Second, lipase is greater than amylase because lipase is more specific, it remains elevated for a longer time and is always preferred diagnostic enzyme. This is a very common MCQ. Third, diagnosis requires 2 out of the 3, typical pain, lipase or amylase about 3 times the upper limit of normal, and imaging findings suggestive of acute pancreatitis. Point number 4, gallstones are most common, alcohol is second most common, and chronic alcoholism leads to chronic pancreatitis. Fifth, Cullen's and Turner's signs suggest hemorrhagic pancreatitis. Sixth, hypocalcemia in pancreatitis suggests severe disease. It occurs due to fat saponification. 7. CT abdomen timing. CT contrast is best done after 72 hours. Early CT may underestimate the severity. Point number 8. Rinker lactate is preferred especially in the first 24 hours. Early fluids reduced organ failure risk. Point number 9. Antibiotics are not routinely indicated. Use only if infected necrosis, cholangitis or extra pancreatic infection. Next, ERCP indication, it is indicated in gallstone pancreatitis with cholangitis. Next, pseudocyst timeline. Pseudocyst usually develops after 4 weeks. Severity, BISAP within the first 24 hours, Ranson's at admission plus after 48 hours. High score means higher mortality. Now the rapid fire one-liners. Lipase greater than a mile is for diagnosis. Gallstones are most common cause. Alcohol most common chronic cause. Early enteral feeding preferred over TPN. ERCP indicated in gallstone pancreatitis with cholangitis. Pseudocyst develops after 4 weeks. Bicep less than 3 means mild. Greater than or equal to 3 means severe. So this was acute pancreatitis. If you found this video useful, make sure to like, share and subscribe. Thank you.